Hi everyone, I'm Lisa Lee. I'm currently the program coordinator intern for Healthy Rural California. And today I'm excited to announce that we're doing our first interview being conducted for the Health Equity Campaign. Specifically, today's topic is global health equity. And today I have Dr. Robert Bernstein. He's currently the health officer for Butte County Public Health. And just a little rundown of the Health Equity Campaign. We're using this campaign to drive the conversation of health equity and also discuss what we can do to make a difference, to see a difference in the future and how health equity can look like in our communities. And so, Dr. Bernstein, thank you so much for joining us here today. Would you like to talk a little bit about your professional experience before we get started?
Let me turn my phone off right away. Yeah, so, okay, I'm a physician and public health professional. I'm board certified in public health and preventive medicine. My professional public health career began with an assignment or training course at the Centers for Disease Control as what's called an epidemic intelligence service officer. Some people may recognize that California and Florida have their own state epidemic intelligence service programs. And we can talk about that in more detail on another occasion. But I worked for the Centers for Disease Control and CDC partners like USAID, the Agency for International Development, the World Health Organization, UNICEF, the Asian Development Bank, Doctors Without Borders, and a number of other partners, including some commercial firms like Pfizer and Wyeth, over a period of 32 years or so. And much of that time, maybe half of that time, was working overseas in low and middle income countries, initially in Indonesia and in a number of other countries in Southeast Asia, South Asia, Eastern Europe, and the Middle East. So I've had some opportunities for learning about cultural differences and issues around equity and lack of equity, disparities and so forth in a number of different national settings as well as international settings around the globe.
All right. Thank you, Dr. Bernstein. Given your experience, you are the perfect candidate to be discussing today for global health equity, as you have much experience outside of the U.S. So given that, my first question is, how do you view the status of global health presently, and how do you think it will improve in the future?
So I would answer that question from experience that I described for the CDC and for a number of global partners. You may know that the Centers for Disease Control has, I believe, 32 or more, maybe as many as 60 countries in which that's the global we, in which the Centers for Disease Control works with ministries of health to help develop CDC-like capacity to help build public health programs along the lines of the 10 essential public health services that CDC and American Public Health Association and others have described, and to enable those countries to have the capacity to monitor and evaluate the performance of those programs and the results that those programs achieve, and thereby in a continuous fashion to try to improve the design and performance of those programs. So if I look at what's happening now, and I especially take away the 4 years under the Trump administration when we actually threatened to leave the World Health Organization, absolutely incredible thought. My assessment is basically guided by efforts that, I don't know, began, I think, in the, if I'm not mistaken, around the latter part of the 80s, early 90s by WHO to revisit the international health regulations and to try to strengthen them. And in connection with that, to be able to address epidemics and pandemics that have occurred over these last years, and especially over the last 20 months. So if I think about capacities in different developing countries, and the reason I mentioned the international health regulations, there was an effort to independently assess global health security capacity in low and middle income, but across the world in all countries. And recently, the international, what's it called? Let's see, the Institute for Health Metrics and Evaluation, the IHME, at the University of Washington, did an independent evaluation of the extent to which those efforts to characterize global health security were reflected in reality, in capacity, and in an ability to address the pandemic that's affected us over the last 20 months. The results seem to indicate that there's still a lot of work to be done to build public health capacity and implement strong preventive and control programs in many countries. Apart from that, and most specifically in regard to the COVID-19 pandemic that's still affecting so many countries, the disparity, the lack of equity in access to vaccines and other therapeutics is really disturbing, because, as we know, a viral disease like the SARS-CoV-2 disease, COVID-19 disease causing virus, like all other viruses, when it infects an individual, it gets busy replicating itself. And while it's replicating itself, unfortunately, from time to time, it makes errors. And those errors could enhance the ability of the virus that's developed to take actions such as become more transmissible, more easily transmissible, possibly to avert the ability of tests to detect the virus, possibly to reduce the effectiveness of vaccines. So that disparity across the globe is very troublesome from the point of view of the health and well-being, life expectancy of people in low and middle income countries especially, but also for the US, because the more of those errors occur, the more transmission occurs, the more errors occur, the more likely that there'll be Delta-like or even more powerful variants that will arrive on our shores, as well as affect other countries. So that's a long-winded way to talk about the fact that there's more work to be done in global health security, more work to be done in developing the capacity within countries to monitor the performance and evaluate the effectiveness of prevention and control programs, and more work to be done in terms of equitable distribution and access to vaccines and therapeutics. And one more thing I would add is that the evidence has become quite clear that over this past year, the routine vaccines for children that are so safe and effective, that have been demonstrated to be safe and effective for decades, are not being administered as widely, and coverage levels have declined in the US and certainly overseas as well. And this is really troublesome, because we don't need epidemics in addition to this pandemic.
Right.
So I would say that if you ask me what the key issues in global health security are right now, number one possibly is the mis and disinformation available to people on the internet, and the impact that's had on hesitancy to take advantage of the marvelous vaccines for COVID-19 that have been developed, safe and effective vaccines that have been developed for COVID-19, and worrisomely, if that's a word, for the routine vaccines for children as well.
Thank you for answering that question. I feel like you discussed really important points in how we can improve in the future and also quickly as well. In discussing global health security, my next question is actually, what are some of the top global health threats that we are currently facing? And I'm sure the pandemic is one, but I was wondering if you give insight on other issues as well.
Yeah, this past 20 months has been difficult for public health departments, which during the Trump administration in particular, were falling behind in terms of the funding necessary to ensure proper operation and capacity building in public health departments. So that together with the fact that in order to address this pandemic, the first pandemic in more than 100 years, many of the routine activities of public health departments haven't been put on hold, but they have had less personnel able to attend to them because of the requirement that personnel have been dedicating themselves to case investigation and contact tracing, and now more recently, thank goodness that the vaccines are available, to developing and administering rapidly new vaccine programs for COVID-19 vaccines. So as a result of that, a lot of the routine public health programs have not been necessarily weakened, but are not operating at the highest capacity, the greatest efficiency. What that means is that messaging about preventive measures for chronic diseases, for non-communicable diseases, has been limited and affected also by the mis and disinformation that's become so widely available. We just had a possible rabies exposure for a 4-year-old child here, and my estimation is that the hesitancy of the parents to permit the initiation of post-exposure prophylaxis was at least in part to the vaccine hesitancy thoughts that they've had about routine vaccines. And the rabies vaccine, of course, has been around for decades. It's quite safe.
Yeah,
So the evidence is that the pandemic has had some adverse effects on other programs, non-communicable diseases, other communicable diseases, chronic diseases, and so forth.
it seems that the pandemic has emerged the harm and detrimental effects of misinformation, as well as you mentioning the program reduction at capacity and also not being as strong as it was before. That kind of brings me into what I read from your equity, diversity, inclusion statement. I saw that most of your work is focused on the Lean Six Sigma style, particularly with the now updated 10 essential public health services that are provided and defined by the US CDC. I was wondering if you can expand on that and talk more about it in regards of the global health issues we are currently facing.
Well, again, it comes down to capacity, really. Public health work, as illustrated in the 10 essential services, depends on the use of continuous improvement, quality improvement thinking. In other words, you identify a problem through surveillance, which has been weakened or adversely affected because of the amount of attention that staff have had to devote to the pandemic. So you identify a problem, whether it's a new problem or a failure of an existing problem. You then investigate and use qualitative and quantitative methods to try to identify the root causes of the failure of an existing program or the root cause of some new emergent problem, whether it's a new virus or And you then work with laboratories and commercial partners, pharmaceutical companies, and others in order to design a therapeutic or a vaccine, or you, through the root cause analysis, identify what the performance weakness has been, and you make an effort to test a change in that performance, monitor and evaluate the effectiveness of that change, and then put in place an improved program. And it's a cyclical process that requires continuous attention.
Right. And I saw that around that circle, I saw it was a colorful circle. They updated now on CDC. Equity could equal to everything, like you just said, with assessment, policy development, and also assurance. Thank you for explaining how the 10 essential public health services frameworks works. With my next question, I saw that you were a previous county health officer for Tulum County Department of Public Health, and I saw some of your work was done on strengthening public health policies and laws pertaining to non-communicable diseases. And so my next question is, with the alarming rates of heart disease and strokes, how can we address non-communicable diseases on a global level?
Well, are you offering the Nobel Prize?
It's quite a loaded question. It's quite a loaded question.
You know, it's going to sound like my mantra, I guess, but it comes down to capacity and leadership. Leadership that is intent on making use of evidence and information for decision making, recognizing that mistakes get made, and when identified, weaknesses or mistakes when identified, they need to be corrected, they need to be addressed. I should divert just for a moment back to the cycle, because part of that cycle is, you know, in the performance of a program, it can be found that there's a geographic area or an ethnic or cultural group that's less well serviced in 10 or some of the 10 essential services than another group. And that kind of disparity is not necessarily intentional, but once identified, it needs to be acknowledged. The root cause for why it's the case needs to be addressed. So in respect to non-communicable or chronic diseases, we know, just as we've seen in communicable disease like the pandemic, COVID-19 pandemic, that people of color, people with cultural or language differences have been more adversely affected, have higher rates of transmission or higher rates of hospitalization, lower rates of access to monoclonal antibodies, for example, in therapy, because they don't get tested. They can't access, or there's not available testing sites for them, where it's not easy for them to access those sites. And so they don't, in the case of a communicable or non-communicable disease or a chronic disease, they don't learn of the early signs that they may be at risk. And so they either don't or can't access preventive or treatment services because they're not as well informed about them, or have been adversely affected by mis and disinformation in their community or their use of the social media, or historically, like Blacks concerned about therapeutics because of the history in our own country about the treatment of Blacks in trials with syphilis, for example. So again, it comes down to capacity, I think, to implement a system systems thinking approach to public health.
Thank you for that answer. It seems that also in achieving health equity and how you were talking about minority population not being well informed or not receiving those routine mental health screenings to first catch health symptoms, it seems that there needs to be to address different health disparities and also take in consideration of different social determinants of health as well. And that can further contribute to how we can lower non-communicable diseases as well with those program implementations too.
Yep, well said.
Thank you. That just goes to my last question in your experience of public health law and policies. What do you think are some policies that, or maybe some new policies that should be implemented to help our current status of global health?
Well, hang on a second.
No problem.
Hear no evil, speak no evil. An effort to eliminate the Affordable Care Act. I mean, what kind of an idiot as a leader would actually think along those lines? Basically, the policies that have been put in place in the Environmental Protection Agency, the policies that have been put in place for Food and Drug Administration, policies and practices that have been put in place for vaccine programs. All of these policies are safe and effective if implemented properly. And again, it comes back to that cycle of ensuring that if we implement a policy, let's see if it's working as we expected it to work. If we implement a policy and we find that some ethnic or religious or geographic group is suffering disparities in access to the benefits of that policy, we need to be able to acknowledge that and do something about it. We live in a country which, thank goodness, for the most part, has implemented good, strong policies. We live in a time right now when those policies are endangered politically. And my hope is that by addressing and trying to reduce mis and disinformation in social media that so many people seem to depend on, rather than taking advantage of what they can find in sites like those of the Centers for Disease Control and NIH, FDA, media like NPR, BBC, and so forth. And so I'm concerned, as we all should be, I think, about the need to ensure that health literacy is enhanced, beginning in primary school. You know, we need to encourage critical thinking in school. And that's been difficult too these last 20 months. So I don't know if that directly answers that question.
It does. Thank you. Thank you for outlining the importance of addressing misinformation and making sure that everyone's properly informed of health information as well. I really like the idea of introducing health literacy earlier at the ages. So thank you so much, Dr. Bernstein. Is there anything else you'd like to say before we conclude this interview?
No, I mean, let me think. I mentioned the Affordable Care Act. The United States is so far behind some of the other developed countries in thinking about how to make preventive and curative services available to the entire population. Health for all really should be available for all the people in the United States, if it isn't available for all the people in the world. And so I guess I'm a fan of Bernie's perspective when he was running for president. And there's no reason in the world why this country couldn't implement a health insurance program for everyone. Um, Policies and practices that affect health include issues around taxation and how best to tax in a way that allows people to make as much use as possible as the wages they're able to earn. So anyway, that's an area, that's not my area of expertise.
I would agree, though. I would agree that I would love to see envisioning a country, especially here in the United States, where everyone's able to have access to a, a quality healthcare, not just subpar quality healthcare as well. Um, I think that's a goal that I would like to shoot for as well, and I believe a lot of health leaders would like. I know it gets complicated with policies and trying to implement a universal health system here in the U.S., but I think healthcare, it shouldn't be just a privilege, it should be a right. And so that's my input as well, Dr. Bernstein. Thank you so much.
Yep. Thanks for the interview. Good luck with your project.
Thank you.